They can interfere with work, play, and relationships, headaches, and cutting-edge therapies to help cure them. Tonight, on Call with the Prairie Doc. Good evening, and welcome to On Call with the Prairie Doc. All headaches, large and small, impact our quality of life. If we're lucky, a little ibuprofen or some Tylenol will be all one needs. If it requires something more, or if you get them too often, then it's time to seek some special care. More about that tonight. First, let's take a look at this week's Prairie Doc quiz question. It's a challenging one this time. A multiple choice question. Choose only one. Imaging or CAT scan on the head may be recommended if a headache is A, sudden and severe, B, follows a fall or of a blow to the head, C, causes eye discomfort, D, A and B, E, A, B, and C. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only get 10 minutes to get your answer in. We answer your questions about headaches, though, all through the evening, as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Carol Nelson of Avera Medical Group Neurology, Sioux Falls, South Dakota. Thank you for joining us, Carol.
Hi, it's nice to be here.
So it was interesting. I mean, I think I knew this before, but I learned it again tonight as we were talking to the pre-professional kids that help us, that your dad was a doctor. Tell me a little bit about your dad.
So my dad grew up in the small town of Viborg. He was actually born in my grandparents' house.
So he grew up in Viborg?
Mm-hmm, grew up there, graduated from high school there. And then he went to USD, and that was in the days that the School of Medicine, you could only go for 2 years.
Which was my experience too, by the way.
Okay, yep.
And then he transferred to?
Right. He went to Northwestern University in Chicago and graduated top of his class. And he finished with medical school, did a year of residency or internship training, and then he moved to Lake Andes for, I think, 4 or 5 years, and then back to Viborg. And then spent most of his years in Viborg. He actually practiced consecutively in South Dakota for 51 years.
And he was practicing when he died?
Right. And he passed away at the age of 76 and was still practicing.
Yeah. Right up to that week.
Yep.
And
right up to walking into the hospital, right?
He walked into the hospital with a brain
tumor.
Malignant brain tumor.
Yep.
Did that have anything to do with your choosing to go into neurology?
You know, my dad was a huge influence on me as far as going into medicine. I remember wanting to be a doctor since I can remember, actually. But I'm sure I was just mimicking, you know, what my dad did. Yeah. But I was always that kid that was in there if there was blood or, you know, something that could be looked at. Yeah.
You were watching.
I was the one that was right there, and my sister was the one passing out. But so he was a huge influence on me deciding to go into medicine, and.
So you were a Viborg High School.
Viborg Viking.
A Viking.
Yep.
Yeah. So I played the flute.
I played the flute, kind of,
Yeah.
not very well, but I did play the flute.
So I mean, and then you decided, and you went 4 years of medical school in South Dakota.
Right. So I don't know what year it changed, but
70. It changed in 75, I think.
So I started in 86. So yep, I went 4 years. It was University of South Dakota School of Medicine at that time. So I graduated from there, and then I did a year at Sioux Valley Hospital, which, you know, all those names have changed.
Yeah.
So I did my internship year there, and then I went to Vermont for neurology residency. Mm-hmm. And then back here, and I've been back here since 1995.
So that was 3 years of residency, or 4?
Well, I did a year of internship and then 3 years of residency, right? So 4 total.
Four total.
Mm-hmm.
And then when you've, so you've become a kind of the headache guru, you and a couple others in Sioux Falls now. And then Sioux Falls Neurology has become Avera Sioux Falls Neurology.
Right. We were neurology associates, and we
Yes.
were independent for a long time. It gets a little bit hard to stay independent in medicine anymore, and we decided to join Avera, which has been great for us. Our practice stayed really the same. And when I first came here, I was the only female in the group, and I had some interest in headache, but because it's slightly more common in females, I think because of that, I ended up getting more patients that were headache, and my practice kind of just gradually morphed into where I'm almost all headache now.
Yeah, you've done a fair amount of further training in that area, or have you done a lot of research as you?
Right, I've done research. I didn't do a fellowship
Right.
in headache. Back in the time when I finished, it wasn't as common to do a fellowship, but I got into it and started doing more and more, and then you do more continuing medical education in what you enjoy. So I kind of did more continuing education in the headache realm, and the more you do, the more you read, the more you like it, the more you do.
And the more then the better you are at it.
Yeah, well, it's really my passion. I really enjoy what I do, and I really enjoy the headache aspect of neurology.
And we've already got questions, and it's so important to have questions, but I keep thinking about the fact that some of these people, no matter what you do, they still have pain. But it can be the most challenging. I mean, even the world of chronic pain, it also fits the history of chronic headache.
Right.
Once you have it, sometimes you just have to live with it. How many people who come to you with headache actually get significant relief? Would you say 50%, 75%?
Significant relief is probably closer to 80% because there's so many medications and things that we can do now, and we I think probably catch people earlier now before they get into those deep headache cycles because we've got more options. So I think we have a pretty good success rate. There's always going to be some that those headaches just dig in, and we do the best we can and maybe try to decrease their pain or give them a few more headache-free days. It is a chronic disorder, so it's not a curable disease.
No.
Disorder.
We have a question from Millbank. Two questions from a man from Millbank, and he says, in my younger years, I had numerous migraine headaches. Do they return in later years? And that was his first question, and I'll go to the second question in a minute. Have you seen a timeline? Do they generally start when you're younger and then they go away after? Women mostly?
It's more common in women, but it's actually quite common in men. And some of those numbers of being low might because men don't come in for that complaint as often because it's sort of thought of over the years as a female disease. It is clearly both genders, but it is more common in women. It tends to develop. I mean, you can have them as an infant. But
you can have a what?
You can have headaches as an infant, and they might have cyclic vomiting and uncontrolled crying. But they're really common to develop in the teenage years, right around puberty typically, particularly for the females. But you can see them as a new headache disorder up into the 40s even. If they're after age 40 when they start, you worry about other things. Tumor, aneurysm, stroke, meningitis, different things. I do have people where they'll have them for several years and they'll go away, and we don't necessarily have a good explanation for why they go away. And then they'll come back, and sometimes that's because they've gotten an infection or they've got something else, a tumor or something else that's going on. But when I'm visiting with a patient like that, and I go back to their history and find that they did have headaches that were probably migraines, it's much more reassuring when I'm looking at them again with that. If they go away and come back, I'm probably going to get an image, though, so an MRI or a CAT scan.
Something else,
right?
Because generally, when you get it as an older person, it is something else.
Especially if you didn't have them when you were younger.
Okay. Now, this gentleman also said, I have headaches in both eye sockets and temples on both sides. I've feeling of the head ready to burst. What is that? Does that give you any clue or a hint toward a kind of direction?
So it's helpful. For it to be a migraine, they tend to be more one-sided. They can be on both sides. They tend to be behind the eyes. They tend to be more of a throbbing type pain as opposed to a constant pressure. So in situations like that, I don't know, is this the same person? Is
I think so.
So you would think about, again, something going on behind the eyes, like a tumor. You would also even think about the eyes. Could it potentially be glaucoma? Could it be recurrence of migraines that they had when they were younger and they're just coming back? Could it be some inflammation in the vessels, like a temporal arteritis?
Yeah.
With that story, I would want somebody to come in and take a full history and examine them and see what the situation is. But it can be lots of things.
It could be a lot of things. I'd like to know how old he is or she is. Did he say, this is a man from Millbank, so he is too. I mean, that would help us.
Yeah.
Is it if
It
now
changes
it's,
the differential.
Yes, yeah, it does.
Right.
I'm loving these questions. Keep them coming. This is wonderful. We just answer questions all night. What kind of home remedies do you suggest for headaches? Home remedies.
So when I'm first visiting with somebody on their first visit, I try to remember to talk to them about things that they can do that are not a medicine. Like you want to eat on a regular schedule. Don't skip breakfast, which is common. Sleep on a regular schedule. You want to try to minimize stress, but I think we all try to do that. And foods that can be bad or drinks would be alcohol is probably number one. And foods, anything that's like a preserved meat or an aged meat. So lunch meat is particularly bad unless you get it in the deli that doesn't have all the processing with it. And regular exercise is really important. If you can exercise at least 3 days a week, at least 20 minutes, it's been proven that's a really good preventive therapy for headaches. At least 3 days a week, at least 20 minutes. The more the better. But if people can start there.
I like the idea of 1 mile every day. That's my plan.
That sounds good.
And 1 mile is 12 blocks. You just walk 6 blocks away from your house and 6 blocks back, and then you just go home.
Right. Oh, can I finish one other thing on that?
Yes,
with home remedies, I think what they might be asking is, there's things that you can use like magnesium, which is over the counter.
Yeah, has that helped?
That can help. You don't want to go too high a dose or they'll get loose stools, but people with migraines are shown to have a lower magnesium level. We're not quite sure why, but replacing with magnesium every day or every other day can be helpful. Feverfew can be helpful. There's boswellia, which is frankincense, and that's actually one that's proven to be helpful, and you can get all those things over the counter.
Frankincense. It has a religious bent. I don't know why. I mean, where does that come from?
Yeah, it seems like it should be helpful.
Yeah. I want you to respond a little bit more to foods, because I think that question about foods is so important. It surprised me. I had one headache lecturer say, well, orange juice is one bad culprit. Bananas is a culprit. You hadn't heard banana. I
hadn't heard bananas, but grapes. And I actually read more than 12 grapes is
more than
the
12
cutoff.
grapes.
Yeah.
And then this particular person said, a lot of the alcoholic beverages will do it, but vodka is the least.
That's the only one listed as a non-trigger. That's the only one on the OK list.
So you don't mix it with orange juice.
Right, you've got to find something else.
But you're all right with that,
Yep.
everything else. Okay. And I think the aged meats is an issue, you know, the sardines and the kipper snacks, and people who are listening know what kipper snacks are. Our pre-students didn't.
Another thing that's really bad is artificial sweeteners, particularly aspartame or NutraSweet.
Okay.
You know, caffeine gets a lot of buzz being bad, and over the years kind of watching this and talking to my patients about this, I think NutraSweet is probably worse than caffeine as far as a trigger. So I really encourage my patients to go off artificial sweeteners, but particularly if it's aspartame.
What about the ones that are natural? What is
Stevia is the one that's better.
Yeah, stevia.
Yeah,
the stevia vape.
The one with the, I think that's the one with the little green leaf on it.
Yeah.
I don't like any. I like sugar
works
myself, so I don't know
better.
what
Why
all
not
those
use a
are.
little-
Yeah,
It's just a teaspoon.
lots of sugar. Yeah,
Teaspoon of sugar makes the medicine.
exactly.
Are there any new therapies or medications for new daily persistent headaches?
So new persistent daily headaches are really the biggest challenge in headache medicine. Those are particularly refractory.
Now,
And
just explain what new persistent headaches are?
So it's actually exactly what it sounds like it would be. It's somebody that develops headaches. They go from no headaches, or rare migraines sometimes, but they can go from no headaches to all of a sudden having headaches every single day. They tend to be severe. They tend to be all over. They don't necessarily have all the migraine characteristics like throbbing, but they're severe daily headaches that just do not respond to therapies. And really what we try to do is try the different prevention medications, but you want to try to balance, not give them side effects, because a lot of times the medications aren't really helping very much. And then at some point it can just kind of get better or go away. But those are hard. And you really try really hard to treat it as a migraine to see if we can just kind of stumble upon something that's going to help them.
Right. The preventive medicines include the beta blockers, amitriptyline.
Yep, the big ones, beta blockers like propranolol, inderal, metoprolol, nadolol, amitriptyline or nortriptyline. Topiramate or Topamax has probably moved ahead of those as far as a preventive medication. There's Botox, which has been around, a long time, since the early 1990s for headache, but it was approved by the FDA for headache in 2010, so we started using it a lot more because it was covered by insurance then and we had more availability. Botox is a really good preventive medication and doesn't have a lot for side effects, but it's 31 injections each series every 3 months. People tolerate it really well. Migraine patients are used to having pain, and if that's going to help, they're willing to sit there and do
Take
that.
the shots.
And there's a new medication that came out. It's called Aimovig, which is one of the monoclonal antibody medications that just came out. It's a totally different mechanism than the way the other preventive medications work, and it actually blocks pain. It's a CGRP antagonist, and CGRP is a chemical that causes headache in patients. If you give somebody CGRP in studies, they'll get a headache. If you block that, their headache goes away. And so it's a totally new medication. This is also an injection. But
Really cheap, I bet.
It's right, it's as cheap as Botox.
And does it have side effects?
It's got minimal side effects. It lists constipation, less than 3%, some increased tone in your muscles, less than 1% of people get that, and then some injection site reaction. It is a subcutaneous injection that you do yourself once a month. It goes to your home, you keep it in the refrigerator, so it's an easy way to go. It is about $600 a month. This one, we're just kind of working our way with the drug companies now because it's new, but they've got a great program where it's $5 a month. So
for some,
it's been, if their insurance isn't covering it. And then there's a sister to that just came out this week, and I don't know what the trade name is for that one.
So new daily persistent headaches, sometimes are those, do you think maybe just a virus and then it'll go away too?
You know, it might be. That tends to start with some sort of viral infection, so we don't really know the mechanism, but that's sort of the theory that you've ramped it up somehow with a viral infection.
Yeah.
But
okay. A woman from Brandon asked, I had a pituitary gland removed and it was non-malignant. What percentage of pituitary gland tumors are malignant?
That's a neurosurgery question.
Yes, that is.
I don't know that answer. I would just be...
But a percentage are not. I mean,
Yeah.
a larger percentage. In fact, the majority of them, they watch them. They leave them alone. They don't remove them, right?
Right, because that's where all the hormones are regulated there. So
Yeah.
if you remove that, then you've got to have hormone replacement therapy. Right. And yeah, there are a lot of them are benign. Right. Some of them are just even something that formed while your brain was forming, a Rathke's cleft cyst. Yeah. And they can look like it. Some of them are microadenoma, which are very small. And you work with an endocrinologist and a neurosurgeon, but I don't know a percentage, but a lot of them are benign, yes.
Yeah. Can smoking marijuana help with headaches that don't respond to anything else?
So that question's a little tough for me just because it's not legal in South Dakota, so I haven't spent time researching that yet. It is something that helps a lot of different pain syndromes, though. So, I mean, until it becomes legal in South Dakota, we won't be allowed to prescribe that yet.
I would speculate. I've looked at the literature. There's a lot of literature that shows significant relief of pain from marijuana or marijuana oils or the CNB in particular. CNB actually, CBD actually has been able to help particularly children with seizure disorders. So it's important, I think, that we would move forward on it. But it's interesting that it is a Schedule I drug, which means that somebody called it a Schedule I drug during the Nixon era, while that's at the same level of cocaine and heroin, when we know that there's probably, you know, if you compare the opioid deaths of 70,000 in 2017, and yes, how many people have died from marijuana is very low.
Yeah.
So
Yeah.
I think our society's missing a bet here.
Yeah, I think there's a lot of forward movement we can have in that area.
Yeah.
And any pain specialist, and I'll speak, you know, as a headache specialist, anything we have that we can add to our toolbox to help these patients, I am open to it, and I don't have any preconceived notion of what the cannabinoids are, but if they can help and have minimal side effects and low risk, I'm open to using them.
My only thought is that if we made cannabinoids in a controlled way legal, we could better keep our youth from using it, because there's the big rub. We don't want them to be using it. Well, it is not a migraine, but it is chronic and it is constant. The headache lasts all day, every day, and nothing seems to make the headache go away. Find out how one person is trying to control chronic daily headaches.
My headaches are called chronic daily headaches, and I have had them for 34 years, and perhaps longer. I guess I started seeking treatment 34 years ago for these headaches. And they are present from the time I wake up until the time I go to bed. My headaches manifest themselves in my temples, and so it feels like my head is in a vice. And so it's constant pressure in the temple area. It kind of actually almost moves around a little bit, and it radiates into my cheekbones and sometimes down into my jaws, but is always in my temples. It's just whether or not it radiates into other parts of my face. I love humor, but the more I laugh, actually the more it exacerbates the pain in my temples. It's miserable. You learn to live with it. Nothing seems to help. I am in a bad mood much more often than I think I would be if I didn't have headaches. I just sometimes fantasize about not having a headache and how delightful life would be and how fun life would be if I didn't. And I would just, you know, when my daughter says, "Oh, can we go shopping in Sioux Falls?" I'd say, "Hey, yeah, you know, let's get in the car and go," rather than, "Oh man, my head hurts, but I want to do it because she wants to, so I will." Or if my husband wants to go out for dinner, I want to say, "Oh, sure, that would be great. Let's you know, run down and get something to eat." But I just never really want to because I always have a headache. And what about just taking some ibuprofen? Or the other day I mentioned that I had a headache, and someone said, "Oh, I have some Excedrin migraine in my desk. Would you like some?" And I said, I have tried all of that. I've taken 3 and 4 ibuprofen at a time, or I've tried, you know, aspirin, and I've tried this. It doesn't even take the edge off. It doesn't even budge my headache. I've tried over-the-counter medications. I've tried prescription medications, massage, acupuncture, acupressure, relaxation techniques. Nothing seems to work. Nothing even seems to take the edge off the headaches. They are always present. There was one thing that helped, and it was a prescription medication called Topamax. At first I'm thinking, this is a miracle drug. I couldn't believe it. But then I found that it had a side effect that was quite negative, and that was it really impacted my concentration. And I realized that some people actually call it Dopamax because it makes you such a dope. And I honestly felt like I just couldn't remember practically my name sometimes. Recently, insurance companies approved Botox as a treatment for migraines, and also it's been approved in my case for my chronic daily headaches. And so I had my first treatment of Botox in September, and it did help a certain amount. And Dr. Miles said that it wasn't expected to miraculously make them go away overnight, but over the course of several treatments, they probably, if it's going to work, should continue to improve. And they did improve somewhat. And so I'm excited about getting future treatments of Botox to see if that will help, because the toxins, certainly should help paralyze the muscles and should help them relax, and maybe my headaches will eventually go away.
This is your program, and your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225, or send us an email to ask@prairiedoc.org. Thank you, Carol, for all of this. So, interesting case presentation. Person willing to tell us about her headaches. Nothing works perfectly. One of the things that always strikes me that I learned from you was the issue of withdrawal from medicine as a headache cause. Tell us a little bit about that before we go any further.
So they were originally called withdrawal headaches, like a caffeine withdrawal headache. Yeah. Then they changed it to rebound headaches, which I like that term. And then they changed the term to medication overuse headaches, and they did that so that the patient knows what they're doing. So you can get rebound headaches or medication overuse headaches if you're using any sort of pain medication, whether it's Tylenol or morphine or anything in between.
So Tylenol withdrawal.
Tylenol is a big one.
It's a people use Tylenol every time. They'll end up with rebound pain.
Right. And so they tend to get a headache as the life of that drug is wearing off. And so the headache will go away, and then it'll come back as the medication is wearing off, makes you take more medication, and you just end up in this cycle day after day. You tend to wake up with the headache because you didn't take the medication
through the night.
At night, right? And so you wake up with the headache, and
gotta take it.
So it's kind of a self-fulfilling thing, Excedrin is a big one because it's got caffeine in it and Tylenol, and there's aspirin in it too, which doesn't rebound. But
Caffergot was a big deal when I was a neurology. Well, when I was on neurology as a resident. I remember seeing a lady who came in taking just huge amounts of Caffergot, and he said, I just got to put her in the hospital, cover her with morphine.
Right, that was dangerous because it was hard to withdraw from that. That was a little bit before my time. That was used a little bit right when it was starting. That was a big rebounder. Yep. Yeah.
So your take-home message to people who wanted to use ibuprofen or Aleve or Tylenol, non-narcotics.
If you're needing to treat 3 or more headaches per week, you're at risk for medication overuse headaches. And if they're migraines, you probably need to be getting on some sort of preventive medication for the underlying migraine. And because the only way you can get rid of the medication overuse headache is to come off that. But you probably need some help at that point from a doctor.
So, I mean, it's like two things. When a person came in with headaches, I would say, okay, now, I know you're having a lot of these per month, so I'm going to put you on something that keeps them from coming back, a preventive.
Right.
And then I will have you, here's a tool to use if it hits you so that you've got a rescue.
Yep, or a symptomatic medication, or a rescue medication. So a lot of patients, if they have 3 or more headaches in a week, or sometimes even 2 or more, particularly if they're severe, they'll be on a prevention medication to make that they take every day to make the headaches less frequent, less severe, and shorter.
Right.
And then they'll have a symptomatic medication to take at the time that can cause some improvement in 20 to 30 minutes.
So a quick, probably your most common preventative is propranolol?
I would say the most common preventive now is probably topiramate. I do like propranolol a lot too. I think there's a place for a lot of them, but I think number 1 is probably topiramate.
Okay. Yeah. And then one of your best rescues that's now generic and easy and quick is what?
So the best rescue is any of the triptan category. So the triptans would be Imitrex or sumatriptan, which was the first one and is on most formularies, so that's an easy one. Rizatriptan or Maxalt, Elatriptan or Relpax, there's a lot, Zolmitriptan, Zomig, the ones that end in triptan. Those are very effective. They work quickly, 20 to 30 minutes. You can rebound on them, but they used to be really expensive, like $60 a pill, so you can only usually get anywhere from 6 to 9 usually. Sometimes you can get 12, sometimes a little bit more, but so the risk of rebound is less because you're just not allowed to to have that many. So.
But the first one is just as good as the others. I mean,
You know, they're all slightly different molecules, and so if one doesn't work, yes, I will try 3 of them probably before I'd give up on that category.
Okay. And they're usually pretty relatively inexpensive.
They are now.
Okay. A DeSmet man asks, I become very emotional. I tear up sometimes when speaking. I think it's a minor case of a bulbar syndrome, he asked. Can you have a minor case? What's the reason why I'm tearing up all the time?
There's a range of the bulbar symptoms.
Is he describing the bulbar symptom?
Probably. It's a little hard to know with just such a brief history, but any sort of emotion can make you tear up. And you can get that from different things. Sometimes it's from degenerative things such as like a Parkinsonian syndrome.
Right.
You can get it with Alzheimer's. You get them with brain tumors, particularly frontal brain tumors. So there's different things that can bring that on. And so any sort of emotion, even if it's happy, it can make you cry or tear up. And so it can be frustrating to the person. That's a good reason to see a neurologist if you're having that, just to make sure it's not part of something else. Like I said, Parkinson's would probably be the most common. And so that's a good reason to go in and see somebody and get diagnosed.
And I have to tell you, I must have bulbar syndrome because, I mean, a good Hallmark Hall of Fame commercial will make me kind of weep with a little bit of joy, you know.
Yeah, that might be normal emotion.
I think there's this normal thing that happens. My wife had menopause, she stopped crying at everything. I get male menopause, I'm crying at everything. Which
slightly different than bulbar.
Probably a little bit. Okay. A Spearfish woman asks, does exposure to essential oils or perfumes cause headaches in some people? Are there regulations at hospitals and healthcare facilities that prohibit caretakers, nurses and doctors from wearing odorous oils or perfumes, and so patients and people in hospitals aren't exposed to them? What's your take on that?
That's a good question. There's a lot of odors that are triggers, so it's hard to know if it really causes it or if it's just that one more thing, that trigger that tips you over the edge to get a headache. And there's a huge range of different smells that can do that. I don't hear it probably quite as much with essential oils as I do like potpourri and perfumes and some hairsprays and some real strong scented lotions, candles. As far as the regulations, I don't think there are any. I work at the headache center, and we have a policy that there's no perfumes, right? And if you have a scented lotion, it's got to be pretty light. Of course, we can't control what people are wearing in. And so sometimes the room will be scented from somebody that was just there. My preference would be that hospitals and any healthcare environment was scent free, because I deal with this all the time, and it can be quite offensive to people. But it's not right now a regulation.
And you know, I sense that one of the more powerful odors that you smell, you know, perfume odors, is men's underarm deodorant.
Yeah.
And you know, I've never worn deodorant, but somewhere along the line, you know, I was really exercising a lot. It was the summer. I thought, you know, maybe I should start doing it. I know I offended one of the other doctors in my clinic one day, and she blamed the other guy, and I quietly didn't tell her. I will not wear it. I won't. So, I mean, you know, let yourself sweat and not pretend.
There's a lot of scents that are bad. And, I think moderation is kind of one of those key things in that situation, too. Some people don't put on just a little perfume. It's
don't.
Quite overbearing.
You can tell they're coming down the street from a half a mile away. A woman from Parker asks, I have instant headaches that come on really strong and intense, but do end and go away. Do you know the cause of these?
So there's different headaches that can come on really suddenly. You always worry about the thunderclap headache, which is usually more of a concern because you don't know at first, is it a bleed in the brain, or from an aneurysm or something. So if with your first one for sure of those, you definitely should go in and get evaluated. But there's different types of headaches that can come on really suddenly, like cluster type headaches come on suddenly, they peak quickly. Exercise, they're one-sided, and they tend to get a watery eye, runny nose on that side. They're very severe. They last about 15 minutes typically, but if you ever watch a patient in a cluster, it's very anxiety provoking for the patient, but also for somebody watching it. It's an incredible amount of pain. There's some other headaches that come on suddenly, like exercise-induced headaches. So, and you can get those with any sort of sudden release. So you could get that with a sneeze or a cough or a sudden laugh. You can get that with sexual activity. You can get it by bending over to put your shoe on or pick something up, or anything that comes on, you know, suddenly. Wow. Like that. And those headaches should always be evaluated. But they can also, if it's not something emergent, like that requires the emergency room visit and you've had them before, there's medications that work for that. So again, a reason to go in.
It was interesting, you were telling us a case as we were presenting to our pre-professional group earlier about a person who had a perforated CSF plate, where CSF, the fluid around the brain and the spinal cord, was leaking out, and he would get a worse headache when he would bend over.
Right.
There's a lot of things that you need to make sure, because that could be fixed, and it's a risk of infection.
Right.
So go in and be seen if you're having something new.
Right.
And I'm saying that to men and women, but the ones who really need to hear it are the men, because they don't come in.
Yeah.
Do you think that that's a real deal?
Do you know, I think they're maybe a little less likely to come in. I think it seems like over all my years of practice, which is 23 years here now, but I think the men over this period of time are more likely to come in. I think headache specifically is thought as a women's disease, but I think that has changed somewhat over time, and so it's both genders can have it, and the only way it can be treated is if you come in. And migraine is one of the most underdiagnosed disorders because people don't go in.
Yeah. And I don't know, I have a case, my own personal case, of having flown to a medical meeting with my family. We went to Boston for this big deal. And I get down from the deal, and I think I had a low-grade sinus thing. And I would have prevented it, perhaps, had I sprayed my nostrils with Afrin or something before the flight. But I ended up with the most miserable, terrible, focal, one-sided eye pain that wouldn't let go. And it lasted 20 minutes. And
I've had that actually on a flight too. And even though they're pressurized, there is some pressure change, and your brain, particularly the trigeminal nerve, is just really sensitive to pressure change.
Right. So what do you do for people who have, I mean, that was probably a sinus headache, right?
That could have been sinus, but it could have been just from the pressure change, not just from the sinus. I mean, just from, you know, how you have to pop your ears.
Yeah.
You've got to try to pop your ears, and, you know, chew gum or drink some water or something in those situations. But those hurt. Yeah.
Before I go on flights, I kind of spray down. I buy Afrin maybe once a year because I don't use it any other time, but before I go on a flight, I spray it down. I hate Afrin. As a primary care provider, I told people to avoid them because it causes a lot of problems. What about chronic sinus headache pain? We've got a question about that here.
So the interesting thing with sinus pain, I always need to back up and see what people mean by that, because usually people mean it's right here and they'll call it sinus,
right.
Which certainly
and they
could
want
be the
antibiotics.
case. And it certainly could be sinus, but a lot of people that have migraines, they're diagnosed with sinus, a lot of times self-diagnosed.
Yes.
And I think I've even read like 80% of the diagnosis of sinus, again, self-diagnosis all the way through, is migraine. And the reason is because migraine is in that same location, and it's worse with weather change, you know, so people think maybe it's sinuses. And interestingly, the trigeminal nerve, which is responsible for headache pain, there's a branch that goes to your nose. And so you can have, as part of your headache syndrome, have nasal stuffiness and clear nasal drainage. And so then you think, oh, it's sinuses because my nose is running. So then you take Sudafed or whatever, and you can actually rebound from that. And so if it's a really bad throbbing headache and you don't have colored nasal drainage, you have to be thinking migraine.
Okay. You know, when you have mucus, I mean, pus draining, fever, teeth, and one-sided pain, okay, maybe you would benefit. You have,
yes.
They figured it out. 1 out of 6 would benefit from an antibiotic in that scenario. In
Yeah.
other words,
And we don't want to overuse antibiotics.
boy, we want to avoid them.
Yes.
All right, we've got bunches of questions. Thank you. I have a hard time falling and staying asleep at night. Is this a neurologic issue? If so, what can I do to fix it?
The trouble falling asleep that's probably even a better question for you. It can be part of a neurologic issue. More likely it's something else, and then it kind of exacerbates any neurologic issue. We have somebody in our group who specializes in sleep, so pulmonology also specializes in sleep. There's a broad range of things that can cause sleep disorders. Psychologists and psychiatrists do a lot of sleep. That's a big question. Yeah.
I would try to avoid Ambien and the benzodiazepines because there's so much rebound, can't sleep. I mean, it's the same story as the headache. You can't get off of them.
Right.
And you have to go higher doses, and you become dependent on it. I think the major thing is in the SSRIs and the antidepressant group because they have the side effect, and commonly there's an underlying emotional something that's getting at them, and and the SSRIs help in that regard. How helpful is the Aimovig?
Aimovig is the injection that I was talking about.
We just talked about it.
And the studies show that it decreases headaches frequency by about 50%, which is fabulous if you're a chronic daily headache patient, which means you have at least 15 headache days per month. So Aimovig is an interesting one. It's a preventive. It's actually indicated for the chronic daily headache, but also episodic headache. I think it's going to be tough to get that one to be covered by insurance companies,
and
but there were studies on it, and it's a good drug for that as well.
$600 per month?
Per month.
Yeah. Cutting edge therapies for tinnitus.
Oh, I don't know that. That's an ear, nose, and throat question.
Okay. No cutting edge therapies that I know. It's one of those, I have a ton of it with chemotherapy. I think there's a lot of it's just a kind of a peripheral neuropathy that's in that particular nerve, and we just have to live with it. I mean, unfortunately.
Yeah.
Man from T asks, could you explain trigeminal neuralgia and treatment options for this? So what is trigeminal neuralgia?
So trigeminal neuralgia it involves the same nerves. You've heard me talk about the trigeminal nerve. So the trigeminal nerve is what provides sensation to your face, and there's 3 branches, so the top, middle, and bottom branch. And so the top branch is the one that's responsible for migraines, but you can also get trigeminal neuralgia in that area. And trigeminal neuralgia is a slightly different sensation of pain. It's more in your face as opposed to your head. And it's a sharp, shooting, searing, very bad pain. And it tends to be triggered by washing your face or touching your face, brushing your teeth, eating, sometimes drinking something hot or cold. Wind can do it. And that nerve is just irritated, and it can be by different things. So the therapies are to quiet that nerve down. So like gabapentin, carbamazepine, or Tegretol can help. Steroids quiet it down more quickly.
So the anesthesia drugs, the steroids, but you don't want to start narcotics. You don't want to start
because it's a recurring pain that can come back and back and back, and so any chronic pain syndrome, you're best to avoid those and use something that gets more to the root of the problem. So you're trying to quiet that nerve down with the medications that happen to be in the anti-seizure category.
Okay. We have a question from someone from Webster, who's asking about back pain, 4 or 5 operations, screws into the lumbar area, can't exercise, I've been in so much pain, I've lost train of thought. It sounds like a severe chronic pain syndrome. What do you suggest for people who just suffer from this kind of chronic surgery, chronic pain, on and on?
There's actually spine centers at both of the hospitals because of this, potentially a failed back. They've done everything. They've done the surgeries. And from the neurology side, what we do for that is try to see if there's a pinched nerve. It sounds like we're kind of past that point there. So we do the EMG studies and nerve conduction studies, see if we can find a pinched nerve that potentially needs an epidural block, or or maybe go back to surgery. A lot of these patients are going to end up with physical medicine and rehab because it's an ongoing rehab type of situation, and so they kind of take over after we've checked if there's any pinched nerve.
Okay. And I mean, that's a terrible dilemma. Some
Very
people, chronic pain. I think the most important thing is to try to wean off of medicines and get into exercise. And it's sort of like the people who have chronic pain. What is it when you squeeze every muscle and everything?
Oh, fibromyalgia.
Fibromyalgia. Nothing works. Put them on an SSRI and amitriptyline and get them exercising and try to get back to life.
And like this particular one here might be in that tough situation where kind of unable to exercise to get into that cycle, and I see that a lot in patients.
Can't exercise, and
I tell them to do that, but it's different to be able to get up and do it because it hurts more, and again, the spine centers at both places have physical therapists and everybody kind of in line to take over and help that.
I just hope people can stay physically mobile so they never get into this kind of situation. Here is a story about a 55-year-old severe headache. Weather changes triggers her or his pain, and throbbing at the roof of the mouth with the worst headaches. Could it be a stroke?
Strokes don't usually hurt, so it's probably not a stroke. Strokes are more numbness or weakness on one side of the body or the other, trouble speaking, trouble swallowing maybe, but not so much pain unless they've dissected a vertebral artery. So pain is not what comes to my mind first when I'm thinking of stroke. That pain at the roof of the mouth, that's still in that trigeminal distribution. It could be a trigeminal neuralgia. It could be migraine. Both of those can worsen with weather change.
Yes.
So my patients forever have told me that whenever a front is coming through, high pressure or low pressure, they can tell. And then it was studied like in the late 1990s, and I would tell my patients that. They're like, okay, whatever, we already knew that. So it's a very strong trigger. Yeah.
Okay, so we've got short amount of time, a lot of questions. Let's be fast through this.
Right.
A fog, a person sleeps on the back, gets large blinding headaches. Laying on my left side and put pressure on my head, it goes away eventually. Would there be any ideas?
That one I would definitely want to see because that's a complicated one because most headaches aren't going to be positional, but you would worry like a spinal fluid leak or something coming, something with the neck, with a pinched nerve or something. Okay.
Acupuncture is in your armamentarium?
Acupuncture is really helpful. I myself don't do acupuncture, but I send patients for acupuncture, and it's quite helpful for headaches.
And do you have any concept of why it works?
I don't know exactly. No, I know there's a lot of science behind it. I don't know the science, but I know it's truly studied and medically studied, and it's a medically proven therapy.
From Lake Ponset, someone has migraines for 50 years and 15 per month, and she's tried everything. Last 2 years, I've tried massage, everything. Allergy shots have helped some. Sumatriptan helps. But I can only take so much. Side effects. Botox makes me nervous. I do see a neurologist, and what should I do?
So in this situation like this, I would have two things to say. One is that new category of medication just came out, and that's a totally different mechanism, very few side effects. The second thing, when people tell me that Botox makes them nervous, I talk to them about the drug. It is Botox, it's a toxin, but it's very safe. I've done it on my patients since 1998, and I do, like today, I think I did 8 patients. I do it a lot. I've seen very few side effects, and I've seen very good efficacy. Yeah.
Wow. Very good.
Yeah.
And now for the winner of tonight's Prairie Doc quiz question. It's a multiple choice. Choose only one. Imaging or a CAT scan of the head may be recommended if a headache is sudden and severe. A. B. Follows a fall or a blow to the head. C. Causes eye discomfort. D. A and B. E. A, B, and C. And the answer is D, which is A and B. It wasn't the I. In other words, which one didn't work? And the answer is the I was not right. The other two was important because these can be bleeding. It was Carol Haas who answered the question correctly. Thank you, Carol, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local South Dakota radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. The word chronic means long-term and unrelenting, not something that goes away quickly. Add to this the descriptor pain, and you have chronic pain, which happens to too many people in too many guises. There are many examples: chronic headaches, chronic low back pain, the post-herpetic pain following shingles, the neuropathic foot pain of diabetes, and the body-wide muscle pain of fibromyalgia, to name a few. The bad news is that once a person has one of these chronic pain syndromes, it's very difficult to be rid of it, like an unwanted guest who never wants to leave. Surgery or medicines, especially opioids, too often are of no help and sometimes makes things worse. Even injections of steroids, which are invasive, expensive, and often overused, are useless for chronic pain. In the end, too many people still suffer. The pain takes control and the person shuts down completely, becomes inactive, which only turns attention toward the pain. Most helpful is to understand that immobility worsens the situation. If a joint or a muscle is not used regularly, it barks and bites when called upon to be moved, which in turn results in less movement, more pain, and even less movement. This cascade, if unstopped, can result in severe disability and more time to dwell on the pain, often a sense of hopelessness, the addiction potential of pain medicines. This becomes a vicious cycle and is exactly the reason they say use it or lose it. Paradoxically, very often the most effective way to bring people out of a spiraling progressive and chronic pain is to get them moving. Again, the best answer for chronic pain is usually not surgery or more pain medicines. Of course, each case is different, and sometimes a trapped nerve needs release or severe inflammation needs to be rested. However, often careful moving through stiffness and discomfort gives the most long-term relief. As they say, sometimes you have to pain to gain. One patient told me, "My best help was to accept the fact that I had to live with some pain, get on with life, and begin exercising." And the antidepressants didn't hurt either. Studies show that return to function, although not easy, is the key to rehabilitation. Chronic pain doesn't have to mean progressive immobility, disability, and hopelessness. We should remember to accept the pain when we have to, and when advised by the doctor, to move those muscles. You gotta use it or lose it. A big thank you to our guest, Carol Nelson. Thank you so much, Carol.
You're welcome.
For volunteering to come to our studio in Yeager Hall at the campus of South Dakota State University. Her experience was key to our success for tonight's program. Remember, we're getting into the annual flu season. It really isn't too early to get your flu shot. Tonight's show will continue on Prairie Doc Facebook page. We have answers yet to come. It does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
It just moves it to someone else. Suicide, a bad choice. Next time, On Call with the Prairie Doc.
Useful, scientific-based medical information delivered in a respectful and compassionate manner. This is what we get from the Prairie Docs. I am proud to serve on the board of the Healing Words Foundation. Our nonprofit organization works behind the scenes building financial support to continue and expand Prairie Doc programs. We thank the many health providers who volunteer their time to answer our health questions. Significant funding is required to produce and distribute video, radio, and print throughout the region. Your donations will help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. I grew up with Rick Holm on the prairies in DeSmet. On behalf of the Healing Words Foundation,
And on behalf of a lifelong friend,
we invite you to join our mission. Go to prairiedoc.org and click the donate button today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and the South Dakota Academy of Family Physicians,
Avera Heart Hospital, Dakota Allergy and Asthma, Co-Bank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic,
Aberdeen District Medical Society, 3rd District Medical Society, 7th District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.